So of course this is what we're going to be speaking about today, the vertebral artery, and you can see the four segments illustrated here with the V1, V2, V3, and V4. And we'll be focusing our attention on the V1, which, as I've spoken over the years and thought about this disease, I've developed a little bit of a chip on my shoulder. All the prior speakers speaking about the carotid artery, the great evidence that we have about carotid artery surgery and stenting and now TCAR. Why don't we have more of that for the vertebral artery origin? And I think that's a big challenge for you as a Society of Stroke and Interventional Neurology. And I hope that you'll take this on to develop the evidence base we need to figure out how and when to treat. So first of all, I want to convince you this is in fact an important disease. It's not rare, and that it's worthwhile to invest time and energy in studying it and figuring out the best treatment paradigm. You can see here comparing it to intracranial atherosclerosis or carotid bulb disease. The V1 stenosis is not uncommon in autopsy studies or angiographic studies. It's very similar in terms of its frequency to intracranial athero, and you know, of course, how much time and energy has been invested in treating and researching that entity. Even if you compare it to something like subarachnoid hemorrhage and the amount of research and technology and investments that have been put into that disease, it's a very similar order of magnitude, about 25 to 30,000 subarachnoid hemorrhages per year and about 25 to 30,000 strokes caused by V1 stenosis each year in the United States. Now, the good news is that since the last time I spoke, there has been some research, important research done to take the field forward in our understanding of the ability to treat this disease medically and with stenting. And there have been two trials that have been published, one from the Netherlands, one from the United Kingdom. The first one I'm going to speak to you about is from the Netherlands, the VAST study. So in that study between 2008 and 2013, they randomized 115 subjects between stenting and best medical management. Best medical management was somewhat at the discretion of the investigators in the study. They looked at all those patients had TIA or minor stroke before enrollment, and patients were included if they had 50% intra or extracranial vertebral artery stenosis. Now, this is one of the problems with these two studies, is they did mix intra and extracranial artery vertebral stenosis, and we need to do better in that regard going forward in the future, try and focus our attention on the intracranial or extracranial separately. Their primary outcome was death, MI, or stroke within 30 days, and they noticed that in 3 patients in the stenting group and only 2 in the medical arm. Their secondary outcomes, you can see here, were symptomatic stroke thereafter, and there was a numerical difference, but with the small numbers, not statistically significant. And then the 12-month restenosis, they were trying to use CAT scans. This is a good learning point for us. They were unable to adequately assess the vertebral artery stenosis with CAT scans, and perhaps we need to focus on catheter angiography for future studies. It was stopped because of a lack of funding. And again, this similar theme affected the second trial, the VIST study, which is from the United Kingdom. In this study, 186 patients were randomized, 91 to the stenting arm, but only 61 got stented, and 48 of those were extracranial. Again, 50% or more stenosis. This time, the outcome was fatal stroke or non-fatal stroke. And interestingly, there was a numerical difference. So there was more stroke in the medical arm than in the stenting arm. Didn't quite reach statistical significance. Again, ended due to a lack of funding. Finally, they did a pooled analysis of those 2 studies, as well as the Sampras trial. It had been pre-planned, and the outcome there was all fatal or non-fatal stroke. You can see that 186 patients were in the stenting group, 122 were extracranial. There was only 1 stroke in that extracranial population. So again, it shows how safe this procedure is, and we show that in our SVIN registry, and now we're seeing it in a randomized pooled analysis. The odds of a stroke after or on treatment, either stent or best medical management, tended to be lower in the stenting group at 0.63 hazard ratio, but was not statistically significant. So now, how do we treat vertebral artery origin stenosis with this in mind? And I think there are still a lot of questions to be answered. I don't know that anybody has a perfect solution for approaching these patients. One solution would be a very conservative approach, which is what's up on the screen right now, in which patients who have non-invasive imaging and 50% stenosis go on to a catheter angiogram. Only if they have excluded all other sources of stroke would they then get stented, and the stenosis is confirmed at catheter angiography. What threshold should we use? I think a conservative threshold, as I illustrate here, would be 70%, and usually requiring bilateral disease in order to take the patient for a stenting procedure. A less conservative approach would be to just take a threshold of 50% for treatment and allow treatment of unilateral disease and not require bilateral vertebral artery disease. So we want to study this and contribute. The Europeans have taken a step and gone ahead of us, but we need to do our share here on this side of the pond. So I'm hoping to interest you in the audience in getting involved in the voter registry. This is a registry that was initiated with the help of SVIN seed grant funding. It's prospective. We want to collect some preliminary data in this disease and push the field forward. You can see some of the details listed here. A little bit out of time, but if you want to get involved, we have a website that you can visit and get more details. And here's the contact information. Thank you very much.